Many of our members recently attended a Wisconsin Health News webinar presented by our keynote speaker this morning. I shared with Dr. Izard that my one piece of feedback was that I wish that that session had been longer. So I'm so glad that we are able to have some time set aside this morning to have a conversation as part of the PSW annual meeting. I would like to comment that we recognize that we are only having a conversation this morning and that action is necessary on this important public health topic. PSW is committed to supporting our members' action to improve care for underserved populations. If you'd like to hear more about one community partnership, PSW Senior Manager of Pharmacy Quality and Community Outreach, Helene McDowell, recently sat down for a conversation with community leader Sheree Wallace about Sheree's leadership and work with pharmacists. And I'd really encourage you to listen into that session. It's part of the pre-recorded content for this conference. We hope it inspires you to act in your community. And now I'd like to introduce our keynote speaker this morning, Milwaukee native Dr. Tito Izard. He is consistently voted one of Milwaukee's best family physicians and has over 20 years of experience as an educator, instructor, and chief administrator of medical practices with emphasis on urban health issues, clinical practice redesign, and reducing health disparities. In 1999, Dr. Izard was the first African-American family physician to be appointed assistant professor within the University of Wisconsin's Family Medicine Department and Aurora Healthcare's youngest medical director to lead a multidisciplinary clinical practice. Dr. Izard developed and implemented an urban underserved Central City site curriculum for UW and Aurora Healthcare's residency program. This led to his recruiting more African-American physicians than any other residency program in the state. In 2006, Dr. Izard left academics to dedicate his practice to the Central City of Milwaukee. He is currently the president and CEO for Milwaukee Health Services, an independent, not-for-profit, federally qualified health center. His locations serve economically disadvantaged families, of which 97% live below 200% of the federal poverty level. His comprehensive health centers over the years have offered patient-centered clinical pharmacy services via partnership with Concordia University School of Pharmacy, in addition to on-site pharmacy services at both locations. Dr. Izard has recruited more physicians and underrepresented ethnic minority practitioners than any other healthcare practice in Wisconsin, and has become the most diverse provider group practice in the state. His model for recruitment and retention of providers dedicated to working with disparate populations has received national recognition. He served for 6 years on the National Advisory Council for National Health Services Corporate. In 2017, Dr. Izard was asked to serve an additional year as the chairman. Dr. Izard received a BA in social work from Marquette University in 1992. He was Marquette's first social worker to become a physician. Dr. Izard matriculated to the University of Wisconsin School of Medicine and Public Health, receiving his degree in 1996. Currently, he serves on the Wisconsin Medical Alumni Association's Board of Directors. And with that, I just want to welcome you, Dr. Izard. Thank you so much for being with us.
Well, thank you, Sarah, and thanks to your organization. I'm really proud of the fact that you guys are taking time to have this conversation. It's a difficult conversation for everyone, and I recognize within that there is no one solution and there is no one viewpoint only. So as we go along, hopefully we will be able to incorporate a 360-degree perspective when we look at addressing this topic and trying to come up with solutions as far as, all right, so what can we do as individuals? What can we do as families? And what can we do at the community level to continue to address this issue so that all Americans have a right to become as successful as their hard work and their opportunities present?
Thank you. I wondered if you could tell us, we heard a little bit about your career path in my intro, but I wondered if you could tell a little bit about your role with Milwaukee Health Services. And also, I think some of our listeners are very familiar with FQHCs, but maybe some less than others. Could you talk a little bit about that?
Yeah, so I'm a family physician. I still practice seeing patients, taking care of smaller panel patients as I continue with the role as president and CEO. But our organization is a fairly qualified health center, FQHC, often referred to. So I like to, sometimes you hear people refer to community health center, sometimes you hear FQHC. And so the difference between the two, a community health center in general is an organization that looks at itself or addresses the larger community issues. But a federally qualified health center, FQHC, is that community health center plus more. It has specifically received a federal designation status that allows it to be able to care for that community. So what is a FQHC? An FQHC, it has to have three things in order to receive that status. Number one, it has to be located in a health profession shortage area. Number two, it has to be willing to see all patients regardless of the patient's ability to pay. But that does not make it a free clinic. It just means we offer a sliding fee scale for patients. And then number three, the board of directors for the health center, 51% of the board has to be patients or consumers of the services. And that way it makes sure that the organizations is being managed in a way from a board perspective consistent with the needs of that individual community. So most FQHCs are independent, not-for-profit organizations. Sometimes misunderstood, they're not government clinics. They actually really are independent, not-for-profits.
That's so interesting about that board makeup. And I know that a lot of our listeners work for health systems where there may be like a patient advisory committee, or there might be one patient representative at a board table. How have you found that dynamic of having that large, significant representation of the community that you serve on your board of directors?
Yeah, it's actually, to me, it's one of the best models. So one of the things when I was finishing medical school and knowing that I wanted to serve in the inner city, and in particular Milwaukee, because the zip code where I'm currently the president and CEO of our organization is literally 1 mile from where I went to elementary school until I actually went to medical school. So I was one of those people who were blessed to be able to stay literally within that same zip code and same community. But I love the model. So when I talk to students and others who are interested in working for underserved populations, I basically describe there's 5 models of practice that you can use or be a part of that will serve underserved community, whether you're a pharmacist, whether you're a provider, nurse practitioner, physician, PA, and such. So you can either just be a solo or a small group practice where you hang a shingle like in the old days and you start caring for people. You can be a part of a multi-specialty group practice that'll have maybe surgeons and GI doctors and various primary care physicians and such, and we all work together as part of the multi-specialty group. You can be a part of a health system, which I think most of us are familiar with, and those health systems can have clinics all over the city, or in this case in Wisconsin, with some of the larger can be over the whole state. You can be a part of a fairly qualified health center, which what we just kind of described. And so when you look at these different models of practice and saying each one of these models can serve underserved populations, but the way the organization is designed and develops and the rules and regulations may differ from one to the other. So the fairly qualified health center model, being able to make sure that the board of directors, majority of the board as consumers, really allows us to have that most direct influence and experience of what actually is going on in our patients' lives as well as the community, because it's not just patients. The board also is supposed to represent the community. So if you have a community that have a significant percentage of your patients that speak a different language, well, then that really should be represented on the board. In this case, between race and ethnicity, is pretty one of the easier, obvious things that should show representation, and well as economic and those things. So the board representation based upon consumers or users is really a reflection of the community that you're serving.
We often use the term health disparities.
Yes.
Could you talk a little bit about what that means, and maybe what is critical to be aware of in both historically and currently that frames the conversation around health disparities?
Yeah, so I try to simplify it to keep it really simple for people to understand. And so when it comes to just the definition of health disparities, what I like to say is, if you take a vulnerable population, so whether it's, African American, Black African American, we'll actually talk about, some of the differences just within that. But whether you're talking about the Latinx or Hispanic community, whether you talk about Native American community, whether you talk about Southeast Asian, Hmong population, no matter who the vulnerable population, when you take a vulnerable population and you take issues of inequality and issues of inequity, which is justice or fairness, and you mix those two together with that vulnerable population, that is the definition of disparity. In this case, when you look at health inequality, health inequity with the vulnerable population, you will get health disparities. And so those of you who've seen me speak before, I make this provocative statement to say for Native Blacks, health disparities are the direct consequence of being an American descendant of slavery. And it really is a irrefutable statement. It's provocative. And for most who haven't really heard it or explained, it may even cause some level of a visceral reaction. But the reality is, when you look by that definition of inequality and inequity with a vulnerable population, if you look at the American Descendants of Slavery, which ADOS, American Descendants of Slavery, you will say that the whole lineage of that group of people in the United States has never had health parity, meaning some power level of equal outcomes in health. And as pharmacists, whether you have pharmacy students on this call or pharmacists, I'm sure you all in your profession, you've looked at the data that even, and no one is exempt from this whole issue of health disparities. And so even within pharmacy, we know that there's been differences in outcomes for Blacks compared to the majority population when it comes to various levels of pharmacy measured outcomes. And definitely, we look at the whole development of obstetrics and gynecology. Dr. Marion Sims, who was considered the modern day pioneer of modern day gynecology, and those procedures were done. He did 30 surgeries without anesthesia on a 17-year-old Black woman named Anasarka. And just to think about the and even described in his writing of how she just cried out in pain, but then would still say Black people experience less pain. And so that's how it ties into pharmacy and these issues. So whether it's that or whether you move forward through all the different ages, everything most people know about Tuskegee, but whether it's Tuskegee, whether it's the experimentation of various sorts, in this case surgical, whether you're talking about even one of the things that I like to mention that most people even forgot about. We talk about the 1980s and the crack epidemic, and we talk about crack babies. And even for doctors, and I talk to students and I'll talk to some of my peers and ask people, well, what is a crack baby? And have a person, give the definition. Oh, a crack baby, blah, blah, blah. And I say, do you realize there's no such thing as a crack baby? There is no difference between a crack baby and a cocaine baby. And as pharmacists, you all know that, right? But how many of us have been brainwashed, including as physicians? How many of us, even as Black physicians, have been brainwashed into the way we think about, health and healthcare? And so when you look at the studies, even, looking at the crack baby epidemic that was going on in the 1980s, that is out there. If you look at the number of white women who had cocaine in their system and the number of Black women who had crack in their system when their baby was born, there actually were more white babies born with crack in their system, cocaine in their system, than there were, absolute numbers of babies, Black babies with the crack in their system. But we created this whole image in the 1980s of the crack baby. And so those type of things is what I'm referring to when we talk about, or whether, you talk about infant mortality and looking at the significant poor health outcomes and infant mortality. And one of the things that we historically have tried to do, we've tried to relegate all of this to individual behavior, because that keeps us comfortable. Because if we can rationalize and explain it based on the individual behavior, then it keeps us comfortable. But what we need to do is disrupt that comfortability that we all have, which is that malignant indifference, which we'll talk about a little bit later. But and that's where, unless we're really truly willing to address health disparities and what it means and historically where it comes from, that's why I've made the statement that you cannot talk about health disparities, improving it or changing it, unless you're willing to have a conversation regarding restorative health equity. And restorative health equity is one component of a comprehensive reparations plan necessary for American descendants of slavery.
You did.
So I know I packed a whole lot into that statement.
Yeah. No, that's great. I was hoping you would. I actually wanted to build off of you mentioned malignant indifference, and as when I've heard you speak before, you've talked about malignant indifference, you've talked about institutional racism and structural racism. Mm-hmm. Wonder if you could outline for us what those mean. What are those terms?
So, and I threw up that slide in the background. Hopefully you can see it a little bit without the lights of the computer screen driving you crazy. But what I did is I created this image, I think, to help us be able, sometimes one visual image can help us at least have a foundation of understanding. It obviously is oversimplified in many cases, but it gives us a starting point of the beginning of asking questions. So when you think about the in order to answer the question regarding institutional or structural racism, you have to understand at the beginning, and so right there in the core, when the United States was developed, that the US Constitution was developed with three core cracks in the US Constitution. And that was issues of women's suffrage, that was issues of how the American treaties were being violated and not lived up to, and the issue of Black slavery at that time. And so those three core issues were the three core cracks in the United States Constitution. But even though this country, and again, whites and Blacks, had a civil war in order to address it, when we came through that and we went through this brief period after Civil War, there was a period called Reconstruction that lasted for about 12 years. And during that time, the Reconstruction was an opportunity to essentially address those three core cracks, predominantly addressing the crack of racism. But we all know there was a women's suffrage movement that moved until now we're able to celebrate 100 years of women's suffrage, but in that case, white women's suffrage, right? And then we still have this issue of Native American treaties. So what ended up happening is, even though the country has always been in this process of, how do we form a more perfect union? And America has formed a more perfect union. It is a continual evolution. So this conversation is not to say that there hasn't been progress, but it's to say that we still fail to recognize the three core cracks to various levels and various degrees in this country. And when you talk about the crack of Black Americans, those that have who descend from slaves, then without a doubt, that crack has never been properly addressed, all right? And so what happened is, as the country moved forward, we had on top of that, the Constitution and the three core cracks. The structural racism means the system started advancing forward, but it advanced forward to that first layer that surrounds the circle of the core Constitution is structural racism that were put in place. That means that throughout how our system operated, it's a capitalist system, but it's not a capitalist system that ever allowed Native Blacks to be able to participate properly and fully in a capitalist system. So I like to say that when you think about when you think about mercy and grace, those are wonderful things to have. So what is grace? Grace is to get something that you did not deserve, which essentially is a form of a privilege, right? Or preference. What is mercy? Mercy is to not get something that you did deserve, okay? And again, both of those are wonderful things. But when you have the inappropriate and the unequal distribution of grace and mercy in this country, that is not justice. You cannot have justice when you have the unequal distribution, in this case, based upon racial or ethnic lines. You cannot have justice with the unequal distribution of grace and mercy. So what ended up happening, the structural racism that developed in this country is because the capitalism developed, but it developed with the unequal distribution of grace and mercy. And then on top of that, institutions, which are organizations or businesses, they developed their rules in order to be successful, but it was based upon the structure that was put in place. So I refer to it, in many cases, you have organizations who are obligatory or obligated to be racist because they have to maintain that institutional racism in order to be competitive with all of their peers within their particular market. And so you find many organizations not necessarily just blatant saying they're racist and mean and evil with the intent of harm, but in order to pursue a competitive advantage in their marketplace, they maintain the same obligation of racism in their rules and structure as someone else in order to get ahead. All right? And so that's what institutional racism is. And then the next layer on top of that, so if we look at it as a country, which is the core, when we look at the system, meaning now looking at how things pervasively are moving forward, then you look at businesses or institutions, how they're developing. And then on top of that, you get to the individual level. In the individual level, that's where you may experience individual episodes of implicit bias, individual episodes of how white privilege plays its role. And again, white privilege, because of this issue of the unequal distribution of grace and mercy as it is applied at the individual level. And then what I even put in there, Black paradox, to say, and people say, well, what's Black paradox? Black paradox is post 1965, 64 and 1965, civil rights and voters' rights, there was a movement to try to have some level of inclusion or diversity of, and again, in that time, when you actually looked at the data, again, most of this was most of the significant immigration that's happened in this country. And I think that's one of the things that people who don't live in an urban community fail to really understand when you try to ask, well, why have Native Blacks, American descendants of slavery, why have they had such a hard time when these immigrants come in and they do well? It's because it's the lack of understanding. Prior to 1965, the number of immigrants from minority countries, what we call ethnic minority countries, was extremely low. All right, at that time in 1965, you're talking about 99% of Blacks in the United States had some lineage to slavery. But now, when you look at Blacks in America, about 20% of Blacks in America are now have some form of lineage to immigration that has occurred post 1965. So when you think the Black paradox is that 20% or so of Black professionals, whether they're, educationally or academically professional, like myself as a physician, whether you're talking about a Black person who is in the arts or industry where, professional sports or art and entertainment that has a pretty significant income, then what has happened is for the majority of society who has very limited exposure to Blacks, they see the success of that 15, 20%, and therefore that becomes an overrepresentation in the media to say, oh, look, Black people are actually doing well. So in the 1980s, when the Cosby Show ran, and Black people, again, my conversation is to Black people and white people and everyone, because the masking that has happened, the being fooled has happened to all of us, not just to white people who live in northern Wisconsin who never get to see a Black person maybe once a year. Okay, this has been an issue. So in the 1980s, where you took the Cosby Show and you took a physician, remember Bill Cosby, his role, Cliff Huxtable at that time, he was an OB-GYN physician and his wife was a lawyer, and they made it look like a middle-class family, living there in New York. But the reality is that representation was not the true representation of the median or average Black family in America. And so when you look now, so trying to have representation in media was a good thing, but what it did, it created this Black paradox to make it look like the lives of the top 20% of Black folks was the equivalent of the lives of the bottom 80% of Black folks, which it never was.
I think that kind of leads really nicely into the next question or discussion point I had written down here, and that seems as I've heard our country's current conversation around racism, it seems that there's a disconnect between what we are taught and what we experience. Can you comment on these different perspectives and the impact that has on the conversation? Maybe what factors play the greatest impact on individuals and groups of individuals' perspectives? I think this is where you've talked a little bit about like race and rage, and I think those are some great points for our listeners.
Yeah. So I like to, a lot of times when I have a discussion, I like to have people think about the moon. And when we look at a full moon outside and, the beauty of a full moon, I think everyone, when you look at a full moon, you almost have to stare at it briefly and recognize its beauty. But the reality is it's a misnomer. Why do we call a full moon full when we're only seeing that half of it, when the other half of it is completely dark? But we've defined it with a name that is not even consistent with what it actually is. And so when you take that concept, and if you try to apply that to, why do we believe the things that we believe? Why do we call things the way we call them? And start challenging ourselves. I kind of use that as an introduction into a conversation to say, when we look at race and to say, it's about race, it's not about color. And when I say it's about race, I'm referring to race as an acronym, RACE. And so race stands for residence. So thinking in terms of where does this person live? Because where you live, where your residence is, so whether it's a city or whether it's a rural area or whether it's a particular neighborhood in a metropolitan area, your residence significantly influences your thoughts, especially as it comes to race relations. And so that we've had in our country, we always have this conversation between race, ethnicity, and then social class. And so post 1965, we were supposed to have moved in the direction of eliminating race, but we still kept this significant classism issue. And for capitalism, you can say, well, classism is appropriate in a capitalist society. And that may be appropriate, or maybe the most appropriate, if there was an equal distribution throughout those class levels. So to say, if you look at the low class, versus the low middle, upper middle, class, and to say, if there's an equal distribution of people within each of those, and in a society where you had, a free market society of fairness and justice, then you can maybe argue and say, okay, that makes sense. But we never did that in this country. We never reconciled the racial issue, and we transitioned into, classism has always been an issue in the United States, but we tried to move everything away from race into class only without ever reconciling the race issue. So I use this conversation of RACE, of helping us be able to understand, well, why do we believe what we believe? And thinking in terms of where I live significantly influences my belief systems. Thinking in terms of my age. Someone who is a millennial has a lot of different views of society and of their peers, whites and blacks and others, significantly different than someone of the World War II generation. You look at C being for class, meaning your socioeconomic experiences, and really that is not so much of your income, but really your wealth position. Because what ends up happening, socioeconomic class, you can have a person that have the same income level, but one person may have 10 to 20 to 50 times the wealth position than that other person. And so the life experience that they live may be significantly different looking at wealth class versus income class. And then, and that sometimes I interchange the C with the G and say from race to rage, and say G is gender. And so gender identification and how different is light. So that side of the full moon, that illuminated side that you experience, being of one particular gender versus the different experience that you are, if you're, and the darker side of the moon, if you're a different gender that may have a lot harder chance experiences. And then the last one is the E, which is kind of ethnicity. And I actually refer to it as the ethnocultural lineage, because what's actually interesting, if I asked you all right now just to briefly think, define what does it mean to be Black as far as the race Black, okay? And then you have an idea of what Black means, all right? And then I'll say, okay, well, if I think we all agree that race is a social construct. I think we all acknowledge, except for maybe a very small percentage of us who are truly racist and have this idea that there is something significantly biologically different between, different racial groups. But I think most of us realize that human beings are human beings, and the amount of melanin in your skin doesn't necessarily significantly influence your humanity. I think most of us acknowledge that. Okay, so when we say race and we think in terms of Blacks and whites, but if you think in terms of ethnicity, if I say, well, let's think about ethnicity now, and I asked you to, and so if we say if we talk about the Hispanic or Latinx community, and then I would say, well, now if we're going to talk about ethnicity, what does it mean to be a Mexican? And I think most people will recognize that is a specific ethnic group, even though they're part of the Latinx community or the Hispanic community, depends on how you're defining it, but we're not going to get into that level of specificity. Or if you think about somebody who's Puerto Rican, and so your ethnicity, your mindset about ethnicity would be different if you think about that. Or again, like you said, if someone's Hmong, or someone's Japanese or Chinese, or someone who's from Latvia. And so you think in terms of ethnicity differently. But if I asked you, well, define the ethnicity of African American, I think we wouldn't even recognize that we're stumped. There is no definition of African American. Some of us would say, well, African American means that you have a Black person who's here in the United States who has roots to the continent of Africa, okay? Others will say, no, African Americans are those that have lineage to American slavery. Others will say, and so we get confused because I'm an African American. And if you go back 7 to 9 generations, My ancestors were slaves in the United States. Okay. So African American, because I am an American, I'm a descendant of slaves and slave masters. President Obama has many times been called African American, and so is Kamala Harris. And I was using those two examples, not to make it political, but to say President Obama's father was from Kenya and his mother was from Kansas. Okay, African American. You know, Kamala Harris, her father is Jamaican, from Jamaica, and her mother is from India. But she's called African American also. So it doesn't even make any sense, you know, at this point. So you have a group of people, okay, you have about 35 million people in the United States who, yes, we all may share the race of Black, but the ethnicity is significantly different. And that's why I call it the ethnocultural lineage, because it is not just an issue of color, melanin. It is an issue of a life experience. And what we've done in this country is we've never even gave a name to the group of people who are descendants of the enslaved. All right. And what it does, it is resulted in the masking of what it means to be Black. So we're all kind of lumped in together. And so when I talk about, you know, it's about race, it's not about color, that's what I mean. Because until you understand some of these components and you start to look at the full moon means understanding the illuminated and the darkness. And when you think 360 degrees, it gives us now an opportunity to challenge everything that we think we know about something. So I'll stop there and kind of maybe answer some more questions as we go along.
That's great. I'm struck by the takeaway of our perspective interprets our experiences and our experiences create our perspective.
Yes.
I'm really struck by that. So I've also had the opportunity to hear you speak about important economic factors in the US, and you referenced some of those already and how they tie into individuals' health and the health of communities. So I wondered if you could talk a little bit more about that, and then also maybe comment on how those economic factors are impacting the resiliency or lack of resiliency in communities that we're seeing exaggerated impact of COVID-19.
Yeah, thank you very much. Yeah, and it really does, if we take that moment to think about how our experience does influence our perspective of how we look at things, and recognizing, you know, how that all works. Every single one of us, and this was, it's an opportunity for all Americans, no matter what your background is, to really challenge, why do I believe the way I believe? And so when you think, you know, I made that provocative statement that says for Native Blacks, you know, thinking about health disparities are a direct consequence of being American descendant of slavery. But then when you look at it and you say, well, still, why are these issues? When you think about what it means to be an American, what it means to be a citizen, first-class citizenship is when you think about protecting your rights while pursuing liberty, they're mainly demonstrated through the expression of wealth here in America. And that wealth expression means, if you think in terms of the pandemic was a great, unfortunate example that really just shined the light on the lack of wealth. So most people are not aware that when you look at, now I'm going to say Black again because the data was looking at Black, mainly because the data has not acknowledged the fact of the ethnocultural lineage between those who have lineage to slavery versus Blacks who immigrated mostly since 1965, okay? And so when the data talked about, when you look at Black/African Americans, when you look at 50% of Black African Americans in the United States have less than $1 of wealth. And I think you almost have to really pause to understand that. Less than $1 of wealth. okay? When you look at the median actual number itself, so whether you're measuring wealth, but if you actually take away for depreciating assets, like somebody's car and those type of things, the Black or African American has only about $1,300, $1,200 to $1,300 in wealth, whereas the white has about $120,000. Now, you think in terms of what it means to be a first-class citizen in America. If you lose your job, which has happened now in the pandemic, of no one's fault, pandemic, economic crisis now, your stability, your liberty is dependent upon your wealth position, which is your savings. But if you never had that to start off with, what does that mean to your citizenship? When you think about pursuing higher education, so going to college, and then being able to take out debt, the impact that that debt has on influencing how you make decisions of what career you would choose, okay? Or what job. I work in a fairly qualified health center. We make significantly less percentage and absolute dollars wise than other healthcare providers who would work for the big health system and such. So it really is a commitment. But if you economically are not in a situation, if you're coming out of medical school with $200,000, and I've talked to some recent students, $300,000 and $400,000 in debt, total debt between undergrad, everything else, it potentially influence the decisions you make. When you think about your legal rights protection and recourse, and we saw that significantly play out when you look at George Floyd and you look at kind of what's happening, here with Jacob Blake in Kenosha, or many of the other cases in the United States recently. And you think in terms of legal rights protection, someone who has a high wealth position will be less likely to experience the same type of legal related issues as someone who is in a not just a lower income, but a lower wealth position, okay? If you think about political influence, we know political influence is significantly different based upon wealth position. When you think about healthcare, quality and access, both are influenced by wealth position, okay? And then, so when you're talking about Blacks or African Americans, those that have lineage to slavery, you cannot identify one single social determinant of health component: housing, employment, education, nutrition, neighborhood safety, even issues of social cohesion. Every single one of these components are influenced due to a person's wealth position. So when you look at health, when I say health disparities are a direct consequence of being American descendant of slavery, it is that because of the lack of economic inclusion, what Dr. Martin Luther King Jr. talked about in the 1960s, that we got rights, but we never got citizenship. Okay, and so when I say that, what I mean that, I think most of us are familiar that slaves during the time, when you looked at the appropriation, okay, or apportionment in Congress and taxation, that the Blacks at that time were considered three-fifths persons for taxation and apportionment. I'm arguing today that American descendants of slavery remain with three-fifths citizenship. Okay, and it sounds so outlandish, but I challenge every single one of us to prove me wrong. So when we actually look at all the different measurements, when you look at housing ownerships for Blacks is as low as it was in 1965, okay, when some of the housing legislation was passed. And it's around 40-something%, whereas white ownership is about 70-something%. That's actually around 60%, 2/3. Okay. When you look at wealth position, we know that wealth position is less than 2/3. When you look at health outcomes, we know that there's a gap between health outcomes. So when you actually start measuring all these components, none of the components measured, none of them are greater than 60%. You know, we talk about even incarceration and those issues. We know there's significantly higher incarceration rates. None of the components that we would use to measure what it means to be a first-class citizen, none of them exceed 60% for Black people. So my position is that Black people, especially those that have lineage to slavery, remain with three-fifths citizenship.
There's like some questions coming in the chat, and they relate to sort of like, where do we go from here? And I think you said that so well at the outset of your comments. The American Public Health Association and other groups have named racism as a public health issue. At this point in our world and in our conversation, where do we go from here? Maybe you could comment on that individual, that family, that community perspective. How as healthcare professionals can we work to make an impact?
Mm-hmm. Yeah, and I think where do we go from here? I think we're starting where do we go from here? The fact, that, we're sitting here and have the Pharmacy Society of Wisconsin having this conversation. I'm sure you didn't have this conversation 5 or 10 years ago. So I think, part of it is starting with the fact that we're all waking up to recognize that we have been deliberately misled, or we were just malignantly indifferent. Malignant indifference it's not that a person is racist, but what it means that a person is benefiting from the consequences of institutional, structural racism, right? And when we have an opportunity to influence it and we don't, because we don't want to sacrifice, we're contributing through malignant indifference. So we talked about the way the government has set up has put structural racism in place, okay? The way the businesses have operated is they have permitted institutional racism, okay? But as an individual, we have permitted malignant indifference. So the application of the consequences of racism, when we look at our own individual efforts, that's what we have to ask ourselves. Are we contributing to this unfairness due to our own malignant indifference? Meaning, and one of the things I like to ask, so if you're part of an organization and you're asking yourself the question, is our organization obligatory racist or institutionally racist, right? Or promoting it? The way you can answer that question is to say, it's very simple, okay? Is our organization receiving a significant percentage of our revenues as an organization from a vulnerable class of people, okay, which we define vulnerable, right, before? And if you are, then the question is, when we look at, are we wealth extractors, okay, or are we wealth stabilizers? And when you look at your organization, to be a wealth extractor means that you're working with a vulnerable population. So for example, here in Milwaukee, I think it's easiest to say, if you take one of the big health systems that are located, and if they're receiving about 40% of their revenues based upon, African Americans and the Latinx community, just throwing out numbers as an example. Then if you ask, all right, now let's look at your organization and let's look at the median income of employees in your organization, all right? Because what has happened, we've all been fooled to look at diversity and in this nebulous term inclusion without true representation, all right? And so what I mean by that is, organizations can say, oh yeah, well, we have 20% African Americans at our staff. But when you look at the employees, you find that 90% of that 20% are all low-wage workers. So they get to count the diversity, but they never get to be represented in the organization. So if you look at the median salary of whatever your company is, and you say, looking at the top 50 percentile of employees and say, does that now, is the vulnerable population represented in that top 50 percentile? Because that top 50 percentile probably has more influence on the organization's strategic plans and goals. And so you can look at it at the top 50 percentile, and then you can even be a little bit more specific and look at it at the administrative or executive level. So those, and that will tell you right away, as far as a measurement, whether your organization is a wealth extractor or whether you are a wealth stabilizer. Because are you inviting, and that's what I love about the community health center model, because it does exactly that. It invites the population that we are caring for into the actual institutions, operations, and decision-making, so that we can try to do what's overall in the best interest. So that's one way to be able to think about it. Now, as an individual, what can you do? I like to think in terms of, so I ask myself this questions: what are my abilities? What are my desires? What are my commitments? What are my sacrifices? So when you think about what are your abilities are things, so what can I do? Okay, what are my desires? What do I want to do? What are my commitments? What am I going to do, right? What are my sacrifices is the most important question, because thinking in terms of all those other three, but in the end, you're not willing to let go of your privilege. You're not willing to be inclusive. You're not willing to change the structure. And again, that's that obligatory racism part as an organization. And it's very hard because many organizations say, well, we want to, but we're afraid if we do that, we're going to lose market share. Okay, and then it's going to have a cascading negative potential effect. At least that's the way we think about it, right? Because we think this very linear way instead of a dynamic process of how we look at things. But we've been brainwashed to think in those terms, okay? And so for us as an individual, the malignant indifference is getting to that fourth question to be able to say, what am I willing to sacrifice? I am no longer willing to contribute to the racism of this country or to my organization or whatever else. And therefore, I'm going to be able to speak out appropriately. I'm going to help the organization be able to move in the direction of diversity and inclusion, beyond diversity and inclusion to a level of representation. Now, many of you will say, well, how do I do that if I live in northern Wisconsin and we're all white community? We don't have racism here. And I've heard people actually say that literally within the last couple of weeks in some of my private conversations with others. And people don't even recognize the fact that your community doesn't have even 2% of Black people in it. Have you ever asked yourself why? It's not that Black people don't like the country. Black people used to almost all live in the country, right? We were moved to cities. Specifically, we were specifically moved into highly condensed area. All of those things were structurally done, and we're all familiar with redlining and those type of things, okay? But when you now take people who actually want to, the reason why there's still the high consolidation of Black people in urban communities, and within most of the cases, just like a 3 to 5 mile radius, you'll have a good 90% of Blacks within that community, all within that location. And it's still like that in 2020, because right now, and we have this issue right now in debate about suburban and other communities saying, we want to protect our right to maintain our wealth position. We do not want lower income housing to come into our neighborhoods. And some of it is economically conversations. Some of it is obligatory racism comments, because of saying, well, if you put lower income housing, is going to drive down my property values and yada, 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 right? And so and that's the big challenge that we have in this country, is that we've never addressed the issue between, in America, we have individual rights, we have state rights, and we have federal laws. And so federal rights. And so you have this unending conversation of the rights between the individual to be able to live where I want to live and to protect my wealth position without ever having reconciliation of what happened historically. And that's why we are where we are. So what can you do? You start thinking in terms of, first of all, if this is just an eye-opening conversation and you've never even were aware of some of the data statistics that I'm talking about, number one, you start off by educating yourself. And now the fact that whether you can Google or YouTube and you start, there's so many different resources. I would say right now, for those of you that have very little experience, to have an opportunity to work with somebody directly from an ethnic minority group, vulnerable population, then you actually start educating yourself by reading some of these great books, by just you can go on YouTube, and there are a lot of really great less than 10-minute, less than 5-minute videos that will start educating you on some of these topics. And as you become more educated and more informed, you start to have more of a 360-degree perspective of the situation. And then now it allows you to start talking to your family, your peers, your organization. When you hear these comments, you need to be the one to say, well, that's not quite fully true. What about XYZ? Or the reason why the situation is this way. What has happened is we have too many great people in this country who've remained silent because they want to get along with their peers, because your peers allow you to maintain your wealth position. And until people are willing to stand out and challenge the status quo, you're going to contribute to obligatory racism, okay? And so what I do, I've kind of looked at these issues and I break it down to say things that we can do now at the local level to address racism, things that we can do, and so the local municipality level, things that can be done at the state level to start addressing some of these things, things that can be done at the federal level. So whether it's executive orders specifically or whether it's through congressional actions. And so there's always an opportunity for every single one of us to start doing something productive and positive to challenge the status quo.
That is so helpful. I felt like you're reaching through the computer and talking to each of us. Thanks so much. In fact, a couple of the questions that I was getting, a couple of the questions I was getting were like how to have those family conversations and how to look at data, and that educating yourself is so important. As PSW, we have a PSW Educational and Programming Committee that's committed to helping to have some action around providing educational opportunities like this one for people. So
well, I think one thing that can be done there, especially for those that have limited exposures to others, I think one of the things that you can do is just to start challenging yourself with these questions. I guess you have to decide, either you believe that Black people are inherently, structurally, biologically, physiologically different, and therefore sub to white people. You either have to say, actually, I do believe that, okay? But if you don't believe that, if you believe that all lives matter, okay? If you are, people are people, human beings are human beings, they're good and they're bad of everyone. If you believe that, then that right there should tell you there should be an equal distribution similar to other patterns within society. Now, everybody's not always going to be the exact same. So there's always going to be some variation that this particular group may be better in math and science. This group may be a little bit better, physically. This group may be better artistically, but there should be just a slight variation. But when you see, like I just said, when you have 50% of the population having less than $1 of wealth. Okay, when you look at these significantly glaring gaps, when you look at the number of African Americans going into pharmacy, when you look at the number of African Americans going to medical school, you have to ask yourself the question, all right, since I believe that all people are people, then you have to ask, why is there such a significant variance in outcomes with this particular group? And challenge yourself with that question and not let the question only fall on individual merit actions, but say, well, okay, then how did it get there? And then you have to ask yourself the question, in history, was there a point in time where America was racist? Okay, and I think everybody will say, of course there was a period in American history when it was racist. Then the question is, in what year, what decade did America stop being racist? Meaning, in what year, what decade did America actually provide restitution, recompense for its historical racism? Specifically, what did America do? I literally heard on a talk show here in Milwaukee just the other day, a person say on the radio, the person who was hosting the show, that literally said that we've already had reparations. President Obama was the reparations, and welfare was the reparations, and affirmative action was the reparations. Those type of statements are they're so uninformed, because you take an issue, again, of social class, which is what welfare is about, and you try to identify with race. There has never been a specific, any type of restitution for the racial issue. So we transition out of being a racist country, meaning specifically focus in our laws and all of that, but we never specifically done anything. So when you challenge yourself with that question, then, and if you want to be an honest person, 360 degree, then challenge yourself and say, okay, well, what were the actual programs? Because you will find that actually affirmative action, that there have been more white females who benefit from affirmative actions than Black people, and so you start looking at the actual programs and say, no, that was a social program. It wasn't a race-based program. Therefore, there never was any type of reconciliation of race.
Thank you so much. And I am always interested in this conversation and wish it could go on for longer. And really very thankful for your time this morning. Thank you for running us through a great presentation through this conversation. Thanks a lot. Unfortunately, our time is drawing to a close. So I just want to thank you. And in terms of announcements for everyone, we will be transitioning now into Melissa Thiesfeld's presidential address and the installation of our new board members. So we will take a short break and reconvene at 10:30. Thank you, Dr. Izard.
Well, thank all of you for having this conversation. I realize it was maybe uncomfortable, but the reality is I appreciate the fact that you're trying to have a dialogue so that we can just eventually be honest and move forward together.
Thanks a lot. Have a great rest of your day.
All right, you too. Thank you.